Let's just skip the fluff today and dive right into this high-yield review. We are strictly focusing on nailing secondary hypertension presentations for your boards. Now look, essential hypertension accounts for, 90 to 95% of all cases, but it's those secondary causes, that sneaky remaining 5%, that test writers absolutely love to go after. And why? Because these are the cases caused by an identifiable and often totally curable underlying organic issue. So we're going to break down exactly how they present, the pathognomonic physical findings you can't miss, and the absolute must-know diagnostic pearls so you can get 100% on these questions.
So when should your radar actually go off? Well, there are 3 strict criteria that should instantly trigger your brain to pivot away from standard run-of-the-mill essential hypertension. You should immediately suspect a secondary cause if a patient vignette meets literally any of these. First up, refractory hypertension. This means the patient is completely compliant, they're on maximum doses of 3 or more antihypertensives, including a diuretic, by the way, and their blood pressure is still just sky high. Second, look really closely at the age. Essential hypertension usually develops a bit later in life, right? So if the onset is in a patient under 30 years old without any major risk factors, red flags should absolutely be going up. And third, what if a patient has had well-controlled blood pressure for years and then suddenly it exacerbates and becomes wildly unmanageable? Yeah, if you see any of these 3 things, you need to be looking for a secondary cause.
All right, let's look at our first classic super high-yield vignette. This is basically designed to train your pattern recognition so you immediately jump to renal artery stenosis. Picture this. You've got a young female, well under 30, with persistent high blood pressure. But the kicker? The physical exam reveals a bruit occurred over the mid-abdomen or the flank. That sound, that's actually turbulent blood flow struggling to get through a narrowed renal artery. The kidney then completely misinterprets this low flow as systemic hypotension and ramps up the renin-angiotensin-aldosterone system, and that, of course, drives the blood pressure dangerously high. Now, differentiating the underlying cause of that stenosis really comes down to looking incredibly closely at the patient's demographics. It's like a giant puzzle. If your patient is young, particularly a female under 30, like in our last vignette, the cause is almost certainly fibromuscular dysplasia. This is a non-inflammatory, non-atherosclerotic condition that causes abnormal cellular growth right in the artery walls. Conversely, though, what if the vignette describes a 65-year-old guy with a history of smoking, hyperlipidemia, and diabetes who suddenly develops refractory hypertension? In that case, you're dealing with good old atherosclerosis right at the origin of the renal artery. Okay, so how do we actually confirm and treat this? Well, diagnosing requires vascular imaging. You're usually going to start with a renal Doppler ultrasound to check out the patency and velocity of the blood flow through those renal arteries. Lab-wise, it makes perfect sense. Because the kidney is starved for blood, you are going to see both increased renin and increased aldosterone. Now, when it comes to treatment, the algorithm splits pretty dramatically based on age. For adults, medical management heavily relies on ACE inhibitors. And surprisingly, this can actually slow the progression of the renal disease, and then you follow up with eventual angioplasty or stenting. But wait, in pediatric patients with secondary hypertension from renal artery stenosis, we avoid ACE inhibitors entirely. Why? Because they can drastically reduce glomerular filtration and cause hyperkalemia. So instead for the kids, we use calcium channel blockers, or we just go straight to angioplasty. Let's shift gears and move from the blood vessels over to the endocrine system. Here's your next vignette to chew on. A young man is evaluated for persistent hypertension despite diet, weight loss, and being on 4 different blood pressure medications. He also complains of muscle cramps and palpitations, and his labs show severe hypokalemia. So what's the diagnosis? Whenever a vignette features resistant hypertension paired with hypokalemia, and this could be spontaneous or induced by just starting a low-dose diuretic, your mind should immediately jump to an endocrine cause, specifically primary hyperaldosteronism. Also known as Conn syndrome, primary hyperaldosteronism is basically characterized by the independent, totally unregulated secretion of aldosterone. The most common cause is actually a unilateral adrenal adenoma, followed closely by bilateral hyperplasia of the zona glomerulosa. This excess aldosterone forces the kidneys to aggressively reabsorb sodium and water, which obviously drives up blood pressure, while simultaneously dumping potassium and hydrogen ions. And that leads directly to the classic lab findings you'll see, hypokalemia and metabolic alkalosis. Now, the most sensitive screening test here is the morning plasma aldosterone to plasma renin ratio. If you see a ratio greater than 20, that strongly suggests the diagnosis. But here's a massive board pearl. Always check what antihypertensive meds the patient is already on.
Things like ACE inhibitors and diuretics heavily influence renin and aldosterone levels, which can mess with your ratio. If an adenoma is confirmed, you surgically resect it. But if it's bilateral hyperplasia, you manage it medically with aldosterone receptor blockers, like spironolactone or eplerenone.
All right, let's tackle another classic endocrine presentation. Imagine a patient walks in and they are in a complete panic. They're having this acute episode of a severe headache, a racing heart with palpitations, and extreme sweating. All of this is accompanied by a blood pressure reading that is just absolutely through the roof. What is going on here? Well, this paroxysmal attack of sympathetic excess points perfectly to our next incredibly high-yield disease, pheochromocytoma. This is a tumor of the chromaffin tissue in the adrenal medulla, and it secretes massive, just huge amounts of catecholamines, epinephrine and norepinephrine, straight into the bloodstream.
If you want to ace this section, memorizing the 5 Ps of pheochromocytoma is an absolute must. We've got pressure, representing the severe hypertension, pain for the sudden intense headaches, perspiration, representing the profuse diaphoresis or sweating, palpitations for the tachycardia, and finally, pallor. But honestly, the biggest takeaway here is the episodic nature of the disease. These patients often appear completely normal. They have perfectly normal vital signs outside of these acute catecholamine-driven attacks. In fact, it's pretty common for patients with a pheochromocytoma to mistakenly carry a diagnosis of a severe anxiety or panic disorder before someone finally discovers the tumor.
So to lock in this diagnosis, your first-line screening is a 24-hour urine collection. You're checking for elevated catecholamines and their breakdown products, metanephrines. If that comes back positive, you move right to a CT or MRI to locate the mass. Once you've actually found the mass, you have to apply the famous rule of tens. It's a really great quick heuristic to understand the clinical behavior of these tumors. 10% are extraadrenal, meaning they're paragangliomas that can exist anywhere along the sympathetic chain from the neck all the way down to the pelvis. 10% are bilateral, 10% are malignant, and 10% are familial, which means they're heavily associated with genetic syndromes like multiple endocrine neoplasm types 2A and 2B, as well as von Hippel-Lindau disease. Okay, moving right down our endocrine list. Next up, I want you to imagine a patient presenting with central apple-shaped obesity. They've got these wide purple striae across their abdomen, a posterior cervical fat pad, often called a buffalo hump, a rounded moon facies, and they complain of proximal muscle weakness, like having trouble just getting up out of a chair. Plus, they have new onset hypertension. This undeniable physical presentation means you are dealing with hypercortisolism, definitively known as Cushing's syndrome. The excess cortisol heavily upregulates alpha-1 receptors on arterioles, which basically increases their sensitivity to catecholamines. And the result? Significant hypertension. Now, the really crucial part is how we actually screen for this. The diagnostic algorithm for Cushing is notoriously challenging, so test writers love to go after the limitations of our 3 main screening tests. Remember, you need 2 abnormal tests to confirm the diagnosis. First, a late-night salivary cortisol. Normally, this should be low, but in Cushing, it stays elevated. The catch? This test is pretty limited if the patient is a night shift worker with an altered circadian rhythm. Second, the 24-hour urine-free cortisol. This will be 2 to 3 times higher than normal in Cushing, but it's wildly inaccurate if the patient has any renal impairment. Finally, the low-dose 1 milligram dexamethasone suppression test. Normally, this should suppress morning cortisol. In Cushing, the cortisol remains elevated. But beware, everyday medications like oral contraceptive pills and anti-seizure meds can actually alter the metabolism of dexamethasone, which will give you a false result. Let's switch gears and move to a completely different category: structural congenital causes of secondary hypertension. Imagine a young child presenting for a routine checkup. They're found to have surprisingly high blood pressure in their arms, but when you go to feel for their femoral pulses, they're weak and delayed. The child might even complain of leg pain or claudication when running around. This discordant blood pressure presentation, high in the well-perfused upper torso, but low in the starved lower extremities, is the absolute hallmark of coarctation of the aorta. This condition is essentially a severe narrowing, typically located just distal to the left subclavian artery, right near the ligamentum arteriosum. It causes a major obstruction, which drastically increases the left ventricular afterload. You've got to keep these demographic associations in mind because test writers absolutely love to link coarctation with Turner syndrome. On top of that, more than 2/3 of these patients also have a congenital bicuspid aortic valve. On exam, you'll feel that classic radiofemoral delay. You might even hear a continuous murmur diffusely across the torso if the patient has developed a vast network of collateral arteries to bypass the blockage. Treatment is surgical correction, though in critical infant cases, you've got to keep the ductus arteriosus open with prostaglandin E1. That ensures lower body survival until you can get them to surgery. Take a look at this chest x-ray of an older child with coarctation. Do you notice the scalloped, jagged edges right on the inferior borders of the ribs? We call this rib notching. Because the descending aorta is blocked, the body has to compensate. It does this by forcing high-pressure blood through the internal thoracic and intercostal arteries to bypass the coarctation. Over time, these intercostal arteries become massive, tortuous, and dilated. Their constant heavy pulsation physically erodes away the underside of the adjacent rib bone. It's pretty wild to see. You might also spot another really famous radiographic finding on a chest x-ray, the classic 3 sign. Look closely at the silhouette of the aorta here. The indentation right in the middle of the 3 is the actual tight, pinched coarctation segment. The bulge above it is the pre-stenotic dilatation of the aorta and left subclavian artery just getting hammered by high pressure. And the bulge below it? That's the post-stenotic dilatation. Together, they form a perfect number 3 along the left mediastinal border. To wrap up our high-yield review today, I want to leave you with a final provocative clinical scenario that really tests your physiological understanding. Let's say you've diagnosed a pheochromocytoma, you've located the tumor, and you're prepping the patient for surgical resection. Why is it an absolute cardinal rule of medicine that you must administer alpha blockers, specifically phenoxybenzamine, before you give any beta blockers? Take a second to really think about it. Here's the deal. The tumor is pumping out massive catecholamines, right? If you block the beta-2 receptors first, you completely eliminate the peripheral vasodilation they provide. This leaves the massive alpha-1 vasoconstrictive forces totally unopposed, and that will immediately trigger a catastrophic, lethal hypertensive crisis. So always, always alpha block first. And that is a wrap on secondary hypertension. Keep these structured presentations locked in your mind, and you are going to completely crush these clinical vignettes.